Second. Should be accepting her in here. We'll get started in a second. As soon as she hops in here. I don't know why it's not there. She's unable to join. Almost hit me her bootleg. Good evening. There we go. There we go, bootleg.
Well, first of all, it said
it said
just
here we
be
go.
liking me.
Here we go.
The running joke in my household is we gonna call Dr. P and tell him you didn't know how to use your phone.
Yeah, I already know. I was like,
But
I just had me sitting over here looking crazy.
I pressed the button, and then it said I get to request you, which I was like, that's weird because it said you was inviting me to the room.
Welcome everybody to the Dysfunctional Cola Red Bell Techno show.
Instagram be trying to play me. That's all it is to it. Instagram be trying to play me every time.
Blame IG.
How you doing this evening?
I'm all right. I'm chilling.
That's good.
I'm chilling. Yeah. So you got a whole bunch of questions, or what's happening?
All right. So I definitely have submissions. I definitely had people that answered the poll question and said that they actually wanted to join. I think, it took me a while to figure out how to read it.
All right, that's I like that. I like people hopping on. It gives it a new little wrinkle. So that's what's up. And I've people are just reaching out, just like they are really watching this and like it really. All right, this first question: when am I opening up my practice? Let's get the elephant out the room right now. Okay.
Wait, are you on Wi-Fi?
Hold on. It's messing up.
Cause you sound like a robot.
Still sound horrible?
No, you sound good, clear now. But at first, it was doing that robotic.
I'm in the hospital, so.
I know. That's why I was asking what
just let me. I'm on the Wi-Fi, but sometimes that hospital Wi-Fi be trash. So, if it start messing up, then just tell me so I can click off to my regular service. But biggest question. All right, when am I starting my practice? Very good question. Okay, so for everybody, I have quit my practice, quit the Gynecology Institute. There's no more Gynecology Institute. Done. Pierre Johnson Gynecologic Institute, completely done. Long story, I'm not going to even go into it, but when it comes down to taking care of my patients and being able to access and do the things that I need to do to have the high level of care that I want, and if it's not being done, gotta roll. So you can put two and two together and understand why I gotta go. For everybody called and they haven't been able to get to me, or been scheduled for surgeries and haven't been able to get on, or had all of these problems, that's the reason why I'm leaving. With that being said, I am in current negotiations right now for my new practice. My new practice will be through Mount Sinai, which is on the west Chicago, a little bit past Rush. I still will be operating in Ingalls, and I will be operating in Mount Sinai. So I have two hospitals to operate, meaning that I will be operating even more. So everybody that is waiting for surgeries, note that everything will be accelerated, and I will now have a team that actually will take all of this stuff in. So everybody is flying in for surgeries. Everybody's local. I have two places where I'm operating, and I have multiple days per week. So before I had to fight for time here at Ingalls. Now I have Mount Sinai multiple days a week. I'll have Ingalls, so I'll be able to operate. So everybody's waiting. Please be patient. I promise you, all of my surgeries are going to kick back up probably end of August, beginning of September. And then when that happens, like everything will fly. So the 30 some odd patients that are waiting for surgeries right now, I promise you, they will be done within the next few months. With that being said, I do not have like the clinic information. And the reason I can't operate right now is because I don't have a clinic. So I will be, as soon as I get my clinic and information, got to get the money right, got to get all that stuff right, which is being situated as we speak. Once I get the clinic information, which I know where it's at, I already have it, but I can't give it out because the paperwork's not signed yet. So once I have that, every day I'm gonna be on social media saying, this is the number to find me, this is the location to find me, this is all of this stuff. So please keep following and watching. I will have all of that available. I would say probably first couple of weeks of July. My birthday is like on the 1st of July, so I'm about to start being on super coast chill mode. So I would say like mid-July, I should have information and we can move from there. So everybody's asking, please watch this and share it. I will be available then. All right, let's get to the business now. Now we got that out of the way.
No, that was good because trust me, that was on the list a lot.
Because when I said everything, like, oh, you ain't operating no more, you ain't a doctor no more. No, this is what I do. I'm not quitting.
Yeah, when you break the internet, you break my DM too. And people was like, he said he not doing surgery.
Yes, I am.
I didn't even watch the video. Let me go see what he said because
yes, I am. I'm
selective hearing.
I am doing surgeries. I gotta pivot. When stuff ain't right, you gotta pivot in life. You know, that's what anybody in your job, when stuff ain't doing right or what have you, either you stay, deal with the BS, or you pivot. For me personally, exactly. Like I find I take it personally when like people are being impacted or injured or not injured, but just impacted. Like if they're not taken seriously or the things that I want done for them are not being taken seriously. That I can't deal with that. So pivot time for me. But all right, go ahead, take over for a second.
Okay, no problem. All right, so if you're just joining, welcome back. This is another monthly series to our Visit DocP with me. If you're just joining, one of the questions we went over already was about Dr. P's current situation as he transitions to his new practice. But tonight we're going to handle questions a variety of ways. So yes, I have submissions. Those who you responded to my story, those of you who DM me, yes, I have your questions on the list. If you're joining tonight and you want to submit a question, there is a question bubble at the bottom of the screen with a question mark. Enter your question there. If you want to request to be part of the live, send the request to join. You can hop in the live in person and ask your question. Like if you were here last month, you saw we answered quite a few. So definitely feel free to jump in. I got a couple people that responded to the story they wanted to. So I don't remember the names though, but definitely if you want to hop in, send a request. Dr. Pierre is handling the technology side for me. All right, well, I'm gonna start with a submission that was sent already because this person has been waiting a few months and they will probably be on me like, did you ask my question yet?
I'm listening.
All right, so I feel like the guidelines keep changing for your annual screenings, i.e. pap smears. Can you clarify the following for the current year 2022? How often do you need to get a pap smear? How old should you be when you first start? And how old should you be when you no longer need to do it?
Great question. So with that being said, all right, these are the pap smear guidelines. So real quick, number one, this is what a pap smear is for. And I've said this multiple times, but I like to be redundant because I'm sure there's somebody new that's listening that may have never heard this before. So an annual exam is an annual exam. People get confused and think the annual exam means pap smear. Pap smear, annual exam. It's not the case. A pap smear is part of an annual exam. Just like, getting your windshield wiper fluid change is part of your yearly service, or your 3-month service for your oil change. Like, it's just part of it. That does not mean that you do not, if you don't need a pap smear, it does not mean you don't need an annual exam, because The pap smear is just checking the cervix, the cells of the cervix. Remember, you have a cervix, you got a uterus, you got ovaries, you got fallopian tubes, you got breast, you got thyroid, you got all of these things, right? So that means an annual exam is checking your well woman visit, you as a complete person, not just your cervix. All right, now to the question. So with a pap smear, very simply, the reason why the pap smear guidelines have changed is because we found out a lot of information over the years. And what we found out is that the younger you are, right? Well, let me back up a little bit. So when we check a pap smear, we're checking for a couple of different things. Number one, we're checking for HPV. So HPV, or human papillomavirus, is the virus that is the only virus that can lead to a cancer, right? So HPV is prevalent in our society. Like, it's anybody that's sexually active, 95% of all sexually active people will be infected of some form of HPV. Yes, that means you've had HPV infection, right? The problem, or the difference with HPV, especially for women, is that even though there are hundreds of strands of HPV, there are about 15 of them that are what we call oncogenic, or meaning that they can cause the cells to become abnormal and progress into a cervical cancer, right? That's what we're checking for with a pap smear. We're checking to see if, one, you've had those abnormal cells of HPV, and two, if those abnormal cells of HPV are causing the cells of your cervix to become abnormal. So the guidelines are this: unless you are 21 years old, you do not need a pap smear. I repeat again, 21, pap smear. Some of my people were like, oh, when I was 12, I had, yes. If you are 35 and up, yes, chances are, as soon as you got sexually active, whether you was 13, 14, 15, 16, you got a pap smear. No longer the guideline, right? The reason that's no longer the guideline is because we know that if you are super young and you get an HPV virus, it is highly unlikely that you'll get cervical cancer. It's more likely that your body will rid or cure itself of the HPV virus, meaning it'll get rid of the virus, right? The older you get, the harder it is to get. So 21 is now the cutoff. So 21 is when you first get your first pap smear. From ages 21 to 30, we just check the cells of the cervix, right? We're checking to see if there is an abnormality of the cells of the cervix, right? If you have an abnormality, right, depending on that abnormality, you may need to follow up sooner. You may need to follow up in 6 months, a year, 2 years, 3 years. It just, there's an algorithm as far as what you have abnormal and how often you need to come back, right? Because we'll check also too, do you have the high risk strand of HPV? So if you're 21 to 30, if you have abnormal cells, we'll check to see if you have high risk HPV, and you may need to have a colposcopy, which is a biopsy of the cervix, to see if those cells become abnormal. But if everything else is normal, from ages 21 to 30, it's every 3 years, right? Every 3 years you need it. So if you get one at 21, 24, 27, 30. So you really have 4 pap smears if everything else is normal from 21 to 30. Now, mind you, I said pap smear. I did not say annual exam. You should be getting an annual exam at 21, 22, 23, 24, 25. It's the actual pap smear. Putting a speculum in the vagina and taking cells from the cervix should only happen every 3 years at the age from 21 to 30. At the age of 30 to 65, it should be every 5 years. Now, the difference between that is that when you're at age 30, we check both. We automatically check both. We check to see if you have abnormal cells of the cervix, and we also check to see if you have high-risk HPV. If those things are positive, depending on what it is, will dictate what you need. You may need a colposcopy. You may need to follow up in a year to get another pap smear. You may need to, there are other things. You may need a leak procedure. It just depends on what that shows. But it's every 5 years. If it's completely normal at the age of 30, every 5 years, so 30, 35, 40, 45, 50, you literally, if you have everything normal, you'll have to have 7 pap smears. Mind you, I did not say annual exams. You'll have to have 35 annual exams, right? From ages 30 to 65, maybe 7 pap smears. With that, and then what after 65? If you're 65 years old and you have not had any abnormal pap smears, no abnormal cells in your cervix, you're done with pap smears. Over with. Finito. Goodbye. Hasta la vista. No more pap smears. But notice I did not say annual exams. You still need annual exams after 65 because, again, you need them even more so at that age because we got to look at your blood pressure, your thyroid. You know, you still have ovaries, uterus. You still have an increased risk of breast cancer. The older you get, the higher your risk of ovarian cancer, breast cancer. All of those things happen. So you definitely need an annual exam. As far as what you need from pap smear wise is just like I said, from 21 to 30 every 3 years, from 30 to 65 every 5 years, but an annual exam is every single year. That was a whole bunch, but I hope that answered.
That was definitely what to clarify they wanted to know. No, that's amazing. All right. If you're not close,
you seeing these question mark thingies?
Yeah, I see.
You see them? Okay, all right. So
yeah. So I'm doing one more submission and then I'm gonna go to the question box. I'm going back and forth. Okay. Right. If you're not closer to and if you get a request to join though,
I'll let it on.
Okay. If you're not closer to menopause but have a cyst on your ovaries, do you recommend removing with a hysterectomy? If so, what methods are used to prevent the bone issues that you mentioned in a previous video?
Awesome. So cysts on the ovaries are as a case-by-case basis, right? You know, cysts are unfortunately, ovarian cysts are a problem which we don't explain well as providers. And understanding that all cysts don't even need attention is a concept that I want people to actually understand looking at this live. All right. Every woman of reproductive age, every single one that has ovaries is going to have a cyst at some point, right? Typically you have cysts every month. That's when you ovulate, right? Ovulatory cyst is when the egg of a dominant egg in your ovary is dominant and it ruptures, the cyst forms and the egg is released. That release is ovulation, right? So if you ultrasound a woman at the right time of every month, she's going to have a cyst. Those are physiologic cysts. There's nothing that needs to be done with them. If you have cysts that are, you can live with cysts that are even non-physiologic and like hemorrhagic cysts and those types of things. Like, they're not cancerous, but you can see that very clearly on ultrasound. You can see if there's questions about their characteristics of it in the ultrasound that will say or indicate rather if it is a cancer or not. So just because you hear cyst on the ovary does not necessarily mean that something needs to necessarily be done. Things that are problematic that you need to look out for: pain, abnormal bleeding, you know, tenderness to touch, pain with intercourse, right? Those are things that will indicate that there may be a problem there. A cyst is not causing pain and that does not have any abnormal characteristics on ultrasound can just be monitored. So if you're close to menopause and you have a cyst on your ovary, it does not necessarily mean it has to be removed. Now, if there is a reason to believe that it's cancerous or there's problematic, then yes, it may need to be removed. As far as doing hysterectomies with oophorectomies or taking away the ovaries, it goes like this. Like, if you are premenopausal or far away from menopause, your ovaries are still producing hormone. It's still they're of benefit. So your hormones from your ovaries are good for not only your heart health but your bone health as well. So if you have production, if you take that production away too early, you increase your risk for heart disease, bone disease. Now, if you're postmenopausal, it's questionable. So you can either leave them or you can take them, right? You would not prophylactically take them, meaning like you won't just go and just start taking everybody's ovary. You should not do that, right? But if you are postmenopausal and you're getting a hysterectomy, it is an option to also remove the ovaries too, because if you do that, you are decreasing the risk of ovarian cancer in the future. So every woman, no matter what, if you have a cyst, if you had a hysterectomy or not, the older you get, the higher the risk of ovarian cancer. It's still a very small risk, like 1 in 9, 1 in 10, that could possibly have an ovarian cancer, but that risk is still there. So the option to remove the ovaries is a risk versus benefit thing. The older you are and you are going to have a hysterectomy, the benefit of removing the ovary is high, it becomes higher. The younger you are, the risk of removing the ovary versus the benefit of removing it is outweighed. So you have a bigger risk of bone disease, heart disease. Like say for instance, like Hola, you had a hysterectomy. So if we remove your ovaries, if I remove your ovaries, if I remove your ovaries at the time of surgery, then your risk of having osteoporosis or having heart disease in your later years elevates, because you don't have these years of estrogen production that are still there. Now, if this was 10 years past this time, which would, oh my God, I don't know what your fibroids would have been, but if it's 10 years past the time we did surgery, then it's more reasonable because you wouldn't have the production of hormone there.
Right. Okay. All right. So this, I'm going to move to a question, and you didn't get a request to anybody to join, right?
Not yet. Did I see? Hold up. No, these are all questions. So, yeah. So if anybody wants to jump on live to ask a question, this is free healthcare. It don't happen too often, but you can be personal about whatever question that you have, and I will answer it for you. So, but you got to hop on live to do it. But yeah, but go ahead with the question. I haven't seen anybody yet.
Okay. What is your take on a hysteroscopic myomectomy? Do you recommend this type of surgery?
It depends. Well, first of all, anytime that you have fibroid pushing into the cavity of the uterus, absolutely it needs to be addressed. So if you're doing a surgery that is preserving the uterus, then yes, hysteroscopic myomectomy. And hysteroscopic myomectomy means going in with a tool to the cavity of the uterus and removing the fibroids inside of the cavity, right? So that's hysteroscopic myomectomy. But remember or understand that when you have fibroids inside the cavity of the uterus, typically that fibroid is not just completely inside the cavity. It's also some in the cavity and it's some in the muscle of the uterus. And if that's happening, you also have to address the part that's in the muscle of the uterus. You can't do that through a hysteroscopic approach. All right, let me see. You can't do that with a hysteroscopic approach. Like it has to be, you have to go through the scope. There you go. Go ahead, Techno. So you have to do both. So hysteroscopic myomectomies are useful. I perform hysteroscopic myomectomies, but usually I'm also doing something else. So when I perform the excessive procedure, if I'm doing a hysteroscopic myomectomy, unless the fibroid is completely within the cavity, I'm also addressing the part that's in the muscle of the uterus, with a laparoscopic or open approach. If you're doing open, you don't necessarily need to do hysteroscopic because you're getting everything. But if you're doing hysteroscopic, you need to do a laparoscopic or small incision through the belly to address the fibroids that are in the muscle as well.
All right. Yeah, I don't know what the IG is mad at me today. I'm telling you, they playing me. Okay. Next in the question bubble, please explain how the body functions without a uterus and a cervix. I've heard people get long-term symptoms like hair loss and loss of sexual sensation.
No. You do not need your cervix and your uterus. The only point, and so these are false things that happen. So when you hear people talk about like the sex and issues and all those problems, they typically have had their ovaries removed first. So it's anatomy that people don't understand, right? And understanding what their doctor removed and what their doctor didn't remove. And it's like a lot of misinformation that continues to get perpetuated because people don't know exactly what happened and what's going on. They hear hysterectomy, and all hysterectomies aren't built the same, right? Because sometimes you have a hysterectomy and keep your ovaries. Sometimes you have a hysterectomy and take your ovaries, right? And people don't understand that. They get this complete, partial, and all these terms mixed up. And then they say the things that are happening to them, but nobody ever asks specifically what they had. So your uterus has one purpose, only one, just one. That purpose is to get pregnant and have babies. It is a baby house. That's all. There's no other physiologic point of a uterus other than to implant a pregnancy and to house that pregnancy until a baby is formed and has the ability to come out into the real world. That's it. You take the uterus, you take the cervix, you still have pleasurable sex. You still have, you don't go through menopause. You don't go through any of these things because the ovaries are the only thing that produce hormone. So if you take your uterus out, your ovaries are still producing hormone. You don't have these problems, right? So all of these bad things that you hear about hysterectomy are typically not true. Now, mind you, that also goes into how the hysterectomy is done. So I hear women talk about they had pain, long recovery. That can happen because some people can cut you open, have vertical incisions, big incisions. Like Ola will tell you, she didn't have that, right? She had very small incisions and was able to, do her thing, recover or what have you. But her hysterectomy story and somebody else's hysterectomy story could be way totally different. But you have to understand what happened and what somebody went through. But in quick answer, you do not need your uterus or your cervix to have a normal, healthy sex life, regular life, hormonal production life. Like your life will be normal. You just cannot have babies regularly, but you still can have babies. How can you have babies? Your ovaries have your eggs, right? So if you got a hysterectomy, right? Now I tell women this all the time. That's always an option. If your uterus is causing problems, fibroids, bleeding, all these things, it is an option for you to take your uterus and your cervix, preserve your ovaries, take an egg from your ovaries, remove it from your body, fertilize it with your husband's sperm, spouse's sperm, or even a donor sperm, put them together, fertilize those, have a fertilized embryo, take that embryo, put it into someone else's uterus, and allow them to house your baby for 10 months. And it's 10 months because 9 months is 9 months. It's complete 9 months. It's actually 10 months of pregnancy. They house your baby for that time, have your baby, give you said baby, and guess what? You are mama of your own baby with no uterus. That's how it happens. All right, keep rolling.
Excellent. All right. All right. You deem the vagina as a self-cleaning oven, what you said in a previous video. So I got a lot of if you said in a previous video questions today. And that it should be
left. I said it with my chest.
But you said what you said.
I said what I said.
And you deem the vagina as a self-cleaning oven, which you said in a previous video, and that it should be left alone to reduce infection. Right. I was taught that you should open it up and clean it while bathing. As a gyno, what do you consider?
Oh, Colin went black again. Talk about my Wi-Fi. Go ahead. As a gyno, what?
As a gyno, what do you consider the proper way to clean the vagina during baths or showers?
I said what I said. I'm gonna say it again. Don't put your finger. Don't put no towel. Don't put no tool that shoots water. Don't put anything in your vagina other than things that either want or need to go there. Water cleaning, excess stuff to help clean and all of those things do not need to be put in there. When you clean your vagina, outside of the vagina, inside of the vagina. Nothing goes in that hole. Everything, vulva, mons, all of you can clean that and put all types of pH balance, feminine wash, whatever sweet smelling stuff you want on that part. This actual skin that you see skin. When you see things that are epithelialized, like that has mucosa, well, not epithelialized, epithelial is out here. Mucosa on the inside, leave that alone. It does not need your help. Once you start messing with that stuff on the inside, you're causing problems. Don't take your finger, don't take a rag, don't take a tool while you're in the tub, like, oh, maybe I just know. All of this stuff on the outside, you can do whatever you want to. Don't stick nothing in there. Period. I don't know how clear I can get. Your mama, your grandma, all of them, put your vinegar, your apple cider vinegar, whatever, all these things I heard, mineral oil, all this stuff. No, no, and no. Leave it alone. Don't put nothing in the hole. In the tub, in the shower, anytime. Don't clean nothing in there. Now, I mean, obviously other stuff got to go in there, but cleaning agents don't need to go in there.
That was very clear.
Good.
I hope.
I hope so. I don't know how clear I can say. And I'm graphic like that because I promise you, I get this question. I get it like 1,000 times. So if I say it so where it can stick to the memory and that I'm very definitive on it, I will. So don't think I'm being an ass. I'm just really like, if I didn't heard it 100 times, I'm gonna make it real clear.
No, I think the demonstration helps because I think people mix up the outside versus the inside.
I wish I'm gonna give me a little vagina model. That's what I need. Vagina model.
All right. Jumping back into the question box. So if you're just joining, because I know some people are putting them on the screen. If you're just joining, please put your questions in the question box because as you can see, sometimes Instagram plays me and it lets me see some things and not others. It's kicking me off the live, putting me back in it. Put it in the question mark with the bubble at the bottom. And then if you want to request to join the live, just send a request and we'll see it. And
yeah, stop being scared. Make it interesting. Like, yeah, somebody hop on the live and like ask a question like that. I think that was a good idea.
Yeah, we definitely love the live participation.
Yeah.
So make the most of the time.
Yep. Because when it's gone, it's gone.
All right. Okay. The next one in here. Does an ovarian cyst prevent pregnancy?
No. It actually, I mean, so ovarian cyst, you have to have ovarian cyst to get pregnant because cysts on your ovaries are how you ovulate. Now, there are possibilities that if you have pathologic cysts on your ovaries, those can somewhat impede pregnancy, not significantly, but yes, they can. So like dermoid cysts, hemorrhagic cysts, or what have you, if they're large enough, they can inhibit ovulation and they can decrease your risk of getting pregnant. Not to say that you won't get pregnant, but it can decrease your incidence of pregnancy with certain cysts or pathologic cysts.
All right. I have a few fibroids and I've been spotting for almost 4 months straight. I got a Mirena in March to help retain blood, stop cycles because my iron is a 7 due to the amount of clots and how heavy my cycle was. Pain is bad, frequent urination, and painful sex. What should I do until I can get surgery?
Okay, she said fibroids. Say it again, fibroids.
Sorry. I have a few fibroids and I've been spotting for almost 4 months straight. I got a Mirena in March to help retain blood, stop cycles because my iron is a 7 due to the amount of clots and how heavy my cycle was. The pain is bad. I have frequent urinating, painful sex, and what should I do until I could get surgery?
So, well, one, we have to figure out if the fibroids are causing you to have your issues, because it may not necessarily be the fibroids. If they're not pushing into the cavity, they may not be. But specifically, you know, that's one of those where I have to see exactly what's happening and kind of examine, because there are multitudes of things that could be causing you to have bleeding, pain, or what have you. It could be fibroids, but it could be adenomyosis, endometriosis. It could be a lot of different things that could be causing you to have those issues. Mirena IUD actually is one of the most effective at treating the bleeding. But if bleeding is becoming persistent, even with the Mirena IUD, that's something that you're definitely going to have to talk to your physician about. There are some options to help, but it's one of those things where we have to, that's kind of specific to where I'd have to actually see the case and see what's happening. And whoever that is, they'd have to kind of like see me offline so I could look at that a little bit more in depth. Because that's a tough one.
All right.
I don't want to tell nobody something like, he told me. No.
Yeah.
I don't
I
give
get it.
specific advice, right? So if you got specific questions, you gotta come through the consult so I can go through everything. Like, and I know some of y'all y'all get it, and I try to help everybody as much as possible. But if you have like specifics you want me to look into, like your ultrasound, MRI, look at your history, and actually break down all your stuff for you, go through the consult. It's really not that bad, okay? Like, I do it to help, but if I'm gonna sit up there an hour with you talking about all of that stuff, it's a consult. So just www.docforthestreets.com. So go through that, and I will break everything. I just had 3 today. Everybody's happy. Like, I really sit down and I break down all your options and go through your history and stuff. And a lot of times, like, I had somebody call up from, she called from Georgia, I think, today, and it was like, you know, her doctor just really didn't give her options. Like, and I just looked at the ultrasound and was like, look, then, you know, this is something your doctor didn't even see, you know, and this is options, this, and go down and ask her all questions. So that's the best thing to do if you have something specific.
All right. Menopause and fibroids.
Yep.
If you are closer to menopause, should you still consider a hysterectomy for pain relief? Or in your experience, will the pain and discomfort stop with menopause?
Typically not. So if your fibroids are big enough to where they're causing you to have pain, they're not going to shrink a ton or enough after menopause to give you that type of comfort. So if you're just waiting to get to that finish line, you probably are just going to be waiting, because it's going to be, you know, persistent after that. So if you have symptoms, significant symptoms before menopause, those symptoms are not just going to magically go away with menopause. Bleeding is a little different. Because bleeding is not always controlled by fibroids or impacted by fibroids. A lot of bleeding is not really impacted by fibroids. It can make it worse, but a lot of women that have horrible bleeding have it even without fibroids. So getting to menopause may help you with your bleeding, but if you're having symptoms like frequency of urination, pain with sex, cramping, abdominal bloating, or pain when you press on your belly, or like just belly fullness, you're not automatically going to have a 6-pack once you hit menopause because you're not bleeding no more. If that answers the question. So don't expect menopause to just magically make fibroid symptoms disappear. It won't.
All right. Next question. This is actually a sexual health question. Thank you for doing these lives. I have a question that may seem silly, but I feel like I can ask you all. During intimacy, after I orgasm, sex becomes uncomfortable. It almost feels like it causes my cervix to drop, and then my partner hits it so it doesn't feel good anymore. Is that even possible, or is there something else causing my discomfort?
Well, that's something that's going to need an ultrasound. So you need to have an ultrasound, because usually what happens, like if it's just happening right after orgasm, one thing that can happen is like everything dilates and becomes very sensitive. So after you orgasm, the pelvic floor is going to relax. Things are going to dilate. Vaginal tissues are going to dilate. The penis typically like if he orgasms, is going to be at his maximum point of erection. So like there's just not a lot of room in there, and then things are kind of bulging too with the pelvic floor. So that could be a source of pain just with just that alone. Like some people will have just orgasms right at climax, and that's just because everything is at the largest it possibly can be at that point, and you go with deep penetration, it can cause you to have some pain. Now, that is in the absence of any other things like fibroids or any other pathological issues of the pelvis, which, you know, an ultrasound first would be needed, as well as an exam. So that's where I would start with that. Go to your physician and get a thorough exam and see where it says, see if there's anything abnormal that's pushing into your vagina or any problems, and then get an ultrasound, and then you can get a lot of questions answered from there. And then from after that, then you can have things that you can do after orgasm to help reduce that pain, if it's not a pathologic issue that's causing your issue.
All right. This is another you recently said question. You recently said that it's important for a woman to know how to please herself if she will be able to tell her partner how to please her. What do you say to a woman who doesn't believe in pleasing herself and believe that her and her husband can figure it out together?
I said what I said. I said what I said. I said what I said. Like, I mean, you got to get over that. Or if you don't believe in pleasing yourself, which I don't know really why you would not believe in pleasing yourself, because it's not a bad thing, then you're going to have to show him how to please you, right? You're going to have to actually break those things down, like step by step, and see what it is that you really like and how he can impact those, right? But again, I stand firmly behind, if you cannot please yourself, you don't know how to please yourself, you can't expect somebody else to do it. Like, it's just, I don't know how plain to say it like than that. It's not something that you have to continuously do, you know, but at least be like, okay, I like that. I really like that. And I can reproduce that because I like it a lot. And now I can say, hey, do that because I know I like this, and I want you to do the same thing that I did because I know I like it. You can't tell somebody, do this and kind of figure out, because I don't really know what I like, but if you do a little bit, then I might like it. Then, you know, it's just a guessing game. So figure it out first yourself, and then you can explain it to somebody. I stand behind that.
I think that's excellent advice.
Oh, so we got somebody wants to join.
Awesome.
All right, so I'm gonna let them join in real quick. Well, actually, no, we could do it together.
No,
right?
It's not gonna kick me out.
Yeah,
I remember something.
Yeah, that's right. Let's click here. They ran. Oh, there we go. Hey.
Hello.
What's
Hello.
Okay. I decided this is my
What's happening?
first time.
That's
so
all right.
I'm a little,
it's my seventh time.
Right.
And I still
nervous,
ain't got it.
but I'm a little nervous, but I still wanted to get on live and ask. I'm 53 years old.
Okay.
I'm from South Florida.
Okay.
I had a hysterectomy. I don't want to say I had, I think, a BSO hysterectomy, bilateral oophorectomy, and a hysterectomy.
Right. Okay. So yeah.
I want to make sure I said that correct, because I have listened to you.
What most people will say is complete, but it's you had a hysterectomy. So I'm just kind of breaking it down for everybody. So she had a hysterectomy, BSO, which means she had a hysterectomy, means her uterus and her cervix was removed. The BSO part is separate from the hysterectomy, means bilateral salpingo oophorectomy. Remember, everything ectomy is removal. So the salpingo is her tubes, oophorectomy are her ovaries. So she had her uterus, cervix, ovaries, fallopian tubes all removed. Okay, sorry. Go ahead. I'm sorry. What's your name again? I want to address you appropriately.
My first name is Cindy.
All right, Cindy. All right, go ahead. I'm sorry. Good.
I had my surgery November of 2020.
Okay.
2020.
Now, did they do that
I
laparoscopically or did they do it open?
I had laparoscopic.
Laparoscopic. Awesome.
I had laparoscopic. I went home the same day.
Awesome.
You know, it kind of made me get up and walk around. I didn't have I had this. Well, I found out I had the cyst in April of 2020, and then obviously COVID hit, and so I had to wait. And I had to kind of take my life in my own hands, to be honest, because I tried to get an appointment with my regular OB, who I had normally been seeing, because the way I found my cyst was through my employment.
Okay.
Because of my career, my employment gives us the option of having like a body scan every 5 years.
Okay.
So I did a body scan. I'm in the final years of my career, so I did a body scan. And the body scan, they found, the exact verbiage was, they found a large cystic solid mass in the pelvis at midline, which may represent uterine tumor versus adrenal tumor.
So that's that. So they did a CT scan.
Well, my job, yes, my job.
So that's problem number one. But go ahead. I'll explain that in a second. But okay, go ahead.
And that's what they said they found. It says that there's no free fluid or free air in the abdomen or pelvis. And so they gave me the size, and I took that to my primary, and they made a record that the people who do the like I said, it's for employment purposes. They do the physical. When I did that at my job, I took that to my primary. Then after that, I went and saw a doctor, oncologist doctor.
Okay.
Who, because my primary said, well, let's do a CT, another scan, but with contrast, because the first one was done without contrast through my job.
Okay.
So, when they did I took my original body scan with no contrast. I took that, and then I had another scan done with contrast.
Okay.
And I took that to the oncologist.
Okay.
And based on the size, which I was looking at the size, the size was 12.0 by 7.7 centimeter.
That was the mass, or that was your uterus?
That was the mass. There's a large complex cystic focus on the interior pelvis bilaterally, measuring 12.0 by 7.7 centimeter in greatest transverse dimension.
Okay, so you had that was on your ovary.
Yes,
okay.
On my left ovary.
Okay.
So when I went to the doctor, he said that it was what he saw. And I said, well, are there other options? Do I have to have a hysterectomy? Because obviously I'm 53. Mm-hmm. And by that point, I was already menopausal. I hadn't had a monthly cycle in probably at that point over 3 years. I had not had a monthly cycle.
Okay.
Like I said, however, my OB never suggested, hey, well, maybe, so you can balance. Well, I know you talked about balancing earlier, estrogen or progesterone or testosterone or whatever. Nobody ever recommended to me to take anything. So I just kind of figured, I'm just going through the phase of life, no more cycle. So, I wasn't on any type of medication. I just didn't have a cycle. Mm-hmm. And I had a female doctor.
Gotcha.
I had a female doctor.
And so your question is that they need to do a hysterectomy?
I don't know. At this point, I'm not going to even ask that question because I'm probably past that. So what I do for me is I try to focus. My primary care doctor said, a nurse there said, you should focus on a green diet. I try to eat. I lost, since having a hysterectomy, I think I was 207. I'm down to 187. I'm really just focusing on making better habits, supplementing with my greens. And I still eat meat, but, I try to have healthier choices so I don't have the hot flashes. And I don't have the flashes so much during the day, even though I don't have the ovaries. But I heard what you said earlier about is because I'm older, I may not necessarily have those menopausal symptoms because even though I don't have the ovaries, mm-hmm. I don't have ovaries. Right. So I try to use my diet, and losing the weight has helped a lot. Green diet has helped a lot. I do take supplements, mm-hmm. I'm always Googling, I'm always reading. I follow you. I'm not sure how I found you, but I did.
Good.
And that's why I decided to get on. I do have night sweats if I have a bad day of eating some sugar, and I know it's the sugar that's going to cause the sweating. But if I eat very well that day, very little to none. I mean, you know, and I try to have cool sheets. So
that's awesome.
But I don't take HRT because I'm kind of afraid. I haven't really checked like my estrogen levels. But I have to admit though, before the hysterectomy, I could not lose weight. I couldn't. And now since I've had it, I find that it's been a lot easier to lose weight. I have bowel movements. I know it's TMI every day where I wasn't having it before. I don't know if it was possibly that tumor was blocking me from having bowel movements, because I noticed you talked about the bloating and constipation. Mm-hmm. I was experiencing all those things, bloating, constipation. I did have a little bit of pain on my left side, but I thought like maybe I pulled a muscle because I was working out a lot, and I thought maybe I was pulling a muscle or something. So I never thought that it was that.
Awesome. So you said multiple different things, and I appreciate you because it looked like you got all nervous and worked over sweating, got nervous.
If I told you my profession, I shouldn't even be nervous. But go ahead.
No, I appreciate you sharing your testimony. So I'm gonna switch back out, and I'm just going to address like a couple of things that I want people to learn from everything. But your testimony is awesome because it allows me to take some of the things that you said and kind of address some points that other people will probably have. But thank you very much. I appreciate.
But let me ask you one more thing.
Go ahead.
Is it possible to feel better even after all of that? Is it possible?
Yeah,
because I feel better.
Yeah, you absolutely.
I feel better. I don't have the bloating.
Yeah.
I don't have some of those feelings that I was having prior to. And I'm always researching every day. I'm like, is it possible to feel better? It's like my body's responding a lot better. Is it because I'm getting less estrogen?
No, I mean you weren't getting estrogen anyways. You were already menopausal. So you weren't receiving a lot of estrogen, progesterone anyway when they removed everything. So you're feeling better just because your diet, right? So you changed your diet, you lost weight. Those things are more contributory to why you feel the way you feel than the actual surgery. The surgery helped with certain things, but it's your lifestyle and healthy living is why you feel better. Cool.
Okay.
All right. So I'm going to address all of the things that you just talked about there.
Oh yeah, and no HRT.
And no HRT.
Or no ERT or HRT. I'm not sure. I don't even think I need HRT. ERT?
No,
ERT?
it's hormone replacement therapy. So HRT.
Oh, okay, because I don't have a uterus, so
HRT. So let me address these things. Thank you so much again, sweetheart. I appreciate it.
Thank you. I'm gonna be listening.
All right.
Thank you. Okay, I don't know how to get off.
I got you. All right, so real quick. So what she just said was multiple things. So she had her uterus removed, her fallopian tubes, ovaries removed, and it is a couple of things to unpack what she's saying. Like for women that get their ovaries removed, she had already went through menopause. So she wasn't having, so menopause, the definition of menopause means no periods for 12 months, 12 consecutive months, minus any physiologic issues like pregnancy, medicines, or anything like that. So if you are menopausal age, you stop having your periods for 12 months, your ovaries really have essentially stopped producing hormones. So first and foremost, she really had stopped and she had gone through menopause. Now, the misconception of menopause is that everybody's gonna have hot flashes, everybody's gonna need hormones, everybody's gonna have issues. This is false. That's not the case. So everybody experiences menopause a little bit different. Some women have horrible hot flashes. Some women have hot flashes that are not so bad, but that are, bearable. Some women don't have any hot flashes at all. How it affects you, it's really variable from woman to woman. So it's not something that is standard for every woman. Also, too, another misconception is everybody needs hormone replacement therapy. Everybody does not need hormone replacement therapy. I would say approximately maybe 5 to 10% of at least my patients actually need hormone replacement therapy, right? That's when your hot flashes are so bad that you can't function and are impacting your quality of life, and you try all other, non-hormone type medicines, or when you're having vaginal dryness really bad, or other symptoms of menopause that cannot be handled from a conservative standpoint. Those are the only women that need hormone replacement therapy, and they are in a minority. As far as cysts, she had a very large cyst on her ovary. Another thing, which I would agree needed to be removed. I don't necessarily think she needed a hysterectomy. I think they just did that. I think they did that in addition, which is an option, but she didn't necessarily need a hysterectomy. This is what I would caution people about. Remember I said previously that CT scans for gynecologic issues is not optimal. Ultrasounds are much more specific when it comes to gynecologic issues. So if you are getting a CT scan and they're making all these diagnoses off a CT scan, there should be a gynecologist with a brain that says she needs either an ultrasound or MRI. MRI will be gold standard, but MRIs are extremely expensive. Ultrasounds give us the information that we need. She definitely probably need her ovary removed, but maybe not have needed the hysterectomy and as well as the oophorectomy. But removing ovaries again, those are the hormone, those are the organs that produce the hormones. When you are postmenopausal and you have, meaning that you stop your periods, usually, but not usually, those ovaries have stopped producing the hormones. So if you have a pathologic issue like a huge cyst or something, there is a concern about a cancer and it may need to be removed. So that was a lot of information, but out of everything she just said, the biggest thing she said was she changed her diet. She changed her lifestyle. And people think that I'm like a doctor that all I want to do is surgery. All I want to do is like medicine or whatever. I don't, right? I practice what I preach, right? I work out. I eat healthy. Like literally, I just made my meal on my call room because I have to cook and eat. And people will say, oh, I don't have time or whatever. Yeah, like if I got the time to do it, you have the time to do it. Your life and your body depend on you eating healthy. So I promote healthy living, healthy lifestyle, take time to exercise, drink a lot of water, eat healthy. Those things will contribute more to you feeling good and feeling better about yourself and your overall health more than anything else. So if you don't hear nothing else, take the time to meal prep for yourself, to eat healthy, drink a lot of water and exercise, and you'll watch your overall health and the way you feel about life and yourself feel totally better. All right. Enough of me.
No, I think that's great. So since you said that, I'm gonna transition into since we almost at the top of the hour. We
go a little bit longer because that went.
Okay, we go longer. Okay, yeah, I didn't know what you got going on.
Cool. It's cool.
Okay, well, let's transition into a personal question, if you don't mind, since you brought up diet. Are you okay with that? Okay, so someone said, to clarify, in a previous live, you said that your diet is something that you do for fun. Really? Can you please describe what you eat in a day?
Typical day. Typical day, morning, I will either eat oatmeal and possibly some fruit, but usually oatmeal. If I have time for breakfast, I'll eat egg whites with vegetables. Like I'll cut up vegetables with egg whites. I have like possibly some vegan sausage that I'll use, but usually egg whites, oatmeal, almond butter. That's typically my staple. I may have like some protein pancakes I may use. That's my breakfast. A mixture of those things or some of those things. If it's real quick, it'd just be oatmeal. Then snack wise, so usually you should be eating multiple meals a day, right? So and I know it's hard, but you should be having meal, snack, meal, snack, meal, snack. You should have like 6 meals a day total. right? So every 2 to 2.5 hours, you should be eating something, whether it be a small thing, like a snack, or a meal. And a meal, when I say meal, not a full. People think like a plate full of food. We're talking like a palm size of a meat, a vegetable, and depending on where you're at with your diet, like a starch. So that's my breakfast. For a snack, I may have some fruit. I may have like a protein shake, some almonds, something like that, like, a couple hours after I eat my breakfast. Then for lunch, it will be like, some type of lean piece of meat, whether it be, I've really stopped trying to eat like red meat and stuff now. Now I'm really like just seafood, fish. I'll do a little bit of chicken, but it'll be some type of lean meat and a vegetable, whether it be broccoli, beans, or some type of vegetable. And like my my starch, I love yams. Like, they're different than sweet potatoes. I keep telling people, like, yams and sweet potatoes are totally different. So I go out of my way to get my yams. I love my yams. So I eat like, I'll bake my yam, and it'll be like half a yam with my lean meats and my vegetable. But I don't put like all this sugar and all that. It's a straight yam, cut in half, and that's it. So it'll be a lean meat, vegetable, and a yam. That's lunch. And then my other snack will be like, again, like some fruit or some almonds, or a shake at that point, or something like that, like something like high protein, low carbs. And then for dinner, it will be something like whether it be like a vegetable stir fry with some shrimp, or maybe some fish and vegetables. If I have not had my carbs for the day, I may add another half a yam, or jasmine rice, something like that. It's just a very healthy carb. And again, palm of the hand, like 4 ounces. That's it. Not a whole big thing or whatever, unless I'm trying to bulk or put on some more mass, which I've really stopped trying to do. I'm just over that. And then, for the snack after, like before then, I'll have like another shake, or I'll have like some almond butter and something else, like, just a snack. But that's typically in the water. So a gallon of water with all of that stuff being said, like, that's my typical diet per day. And then I'll just make all of those meals through the day, and then I'll do that every day.
And you're committing to that's fun to you. That's what you're saying?
I'm not saying that's fun,
okay.
but
that's what they wanted to clarify.
That's not fun, but like how I feel in my body and taking care of my body, like, that's important to me. I wouldn't necessarily say fun. Jiu-jitsu is fun. Like working out
Traveling,
is fun.
fun.
Yeah, those things are fun. Like cooking is a chore, but actually, like, the results of my body of eating properly, that's enjoyable, I think. Maybe not fun, but it's something I like.
Okay, because I think that's what they was trying to clarify. If you was built different, because you said that your prep is fun.
No, if I said that, I'm mistaken. I would much rather somebody do my prep for me. No, I don't like just sit over there cooking and stuff or whatever. It's not fun. I do like food though. It does make me feel good when I come in and I have like just dope meals prepared for the day. I like that. I'm not saying it is fun, but it makes my day much better when I don't have to worry about my food, and I just have all my food just lined up, my fruits, vegetables, meat, like all that stuff's there. It makes me feel good. So if that's fun, yeah, maybe that's what I meant.
Okay. Oh, that's cool. I think that that's important. Like I said, so people don't get an unrealistic impression of when you watch what you eat, it's work. I will say that. All right.
It is, but it's much needed. You got to invest into it.
I agree. And I agree with, like you said, the portion. I'm telling everybody, don't buy a waist trainer until you buy a food scale. Buy the food scale first.
Absolutely.
It's way,
Agree,
way,
1,000%.
way more important. And a whole
1,000%.
cheaper.
I agree with that 1,000%. Absolutely.
All right. This is another submission. Not sure if this is a health or advice question, but you mentioned as a guy not wanting to be insensitive to a female going through menopause. Since I don't really understand it, is there something we should be doing for our lady to make it seem like we care, or something we should never say about it?
Don't say just get over it, or like just, you know, drink some water, turn a fan and shut up. Like, don't say insensitive stuff like that, because you don't know what it's like having your internal thermometer just kicked on to hell and having to live and function and have everybody else like deal with it. That's tough. So be sensitive in the fact that she's going through something that is extremely difficult. Like, just imagine just going through your day and everything is cool, everybody's fine, and it feels like you're in a sauna for a short period of time. That would piss people off. Like, you know, when you go into a regular sauna, it's like, damn, all right, I'm good, I want to get out. Like, but imagine somebody being stuck in that for 10 times a day. Like, it sucks. So do that. And also, like, talk to your doctor about like solutions, right? Because you should not, if hot flashes are impacting your quality of life, if vaginal dryness are ruining your sex life, it can start really ruining marriages. Like, if you have hot flashes and aren't able to do things and aren't able to function as the matriarch of your household, like, it can really cause problems. So you need to really talk to your doctor, as well as spouses need to understand that it's a problem and go to the doctor with her. You know, I really enjoy when my patients bring their husband and their spouses with them, because I'm able to explain it and they are able to understand better, and they can both work towards fixing it or doing things that will help. So go to that would be my biggest advice. Don't be afraid to go to your gynecologist visit with your spouse. And if your gynecologist ain't cool with that, get another one, because they should be cool with that. So, you know, if you want to know more information about what's happening with your spouse, go to their doctor's appointment with them, if they're cool with it. You know, some people like, they might have shit in there that they like, I don't want you to know that. Stay your ass at home. But as long as y'all cool, you know, y'all should go to each other's doctor's appointment. I believe in that.
All right. Another submission. What actually are fibroids made of?
They are just smooth muscle cells. So it's like, they're just muscle. They're cells of muscle, really. That's it. That's all. That's how I can explain it to you. Benign ones. It's just muscle cells. They're not, and they're not all built the same. Like, if y'all look at my page, you know, y'all saw me like pulling out this spongy, huge, like, just fibroid that kept coming out like a clown car. Like, her fibroid was like just totally different than like Cola's fibroid. Like, they're still the same cells, but sometimes they go through different things. Like, sometimes they're degenerating, meaning they haven't had like blood supply or oxygen, and then they start breaking down and be different, but they're all pretty much the same thing.
All right. So how we looking on time? Because, you know, the list be so long, I can't even send it
We
to
good.
you anymore.
I'm cool. Keep rolling. We good.
Okay, because I was gonna say, trust me, I could go on forever. People send a lot of stuff.
We good. Ain't nothing going on here, so I'm all right. Keep rolling.
All right.
As long as everybody interested, we cool.
This is a good one. Does being a gynecologist, whether you're a male or a female, make you more sexually experienced than the average person? Does it interfere with relationships, making it harder to be with somebody that wouldn't have the same level of experience or understand anatomy the same way?
Ooh, that was a good one.
I told you. I get a lot of people.
That was a good question. That was an awesome question. I guess I gotta be careful how I answer that one. Yeah, so I would say yes. So yes, it should make you more experienced. Like, for me, like, totally understanding female anatomy definitely gives me a better understanding than 99.9% of men, I think. So Yeah, I would think so. Anybody that has ever experienced anything with me, they would probably agree, I would think. Um, so, but as far as like, does it interfere with somebody that's not as experienced? I would say no. I mean, that really kind of just depends on the person. Like, if you are a patient person and, you know, about like teaching folks and like, you know, really just taking your time with people, like it should not, unless people are just resistant to learn or resistant to like being taught stuff. It shouldn't cause a problem relationship wise. But yes, if you have a person that understands female anatomy, which I think, and I've seen that with men, like just being a man and getting into, you know, men conversations. I listen to men talk about stuff and they have absolutely no idea about women and their bodies. Like they have none. So I already know that it transcends about all men. You know, the misconception of men is like, man, the harder you do it, the better she gonna like it. And that's typically not the case. But most men feel that, like that you all are really penetration ecstatic. That penetration floats your boat when it's really not. It's more clitoral stimulation is what most women like. There has to be some type of, you know, clitoral stimulation like involved in it. So having that conversation, and that's not everybody. Some women do just like really like penetration, like, you know, but that's a conversation that typically have to have between men and women. But men typically believe that, you know, one size fits all. It's like, if she like it, she gotta like it. She gotta like it. Everybody like it. I just do it this way and everybody like it. It's just not the case. Every woman is different, and understanding that every woman is different and that there's a psychology around sex, and you also have to, you know, put the psychological aspect of sex with the anatomical aspect of sex, with the physiological aspect of sex, and put that all in together with the individualistic person and what they like and what floats their boat. And like, you know, maybe going out to dinner or romanticism kind of gets them into this type of mood. But it's a whole bunch of stuff that goes into it. But typically men don't know about it. And then I would say the same thing about women too. Like, hey, women are not, you know, don't know as much about men as they think they know. You know, it's just an issue with communication across the board, I think. I know that was a whole go around to the question, but
No, I think that's a good point. I think that people don't take the time to say, "Hey, what do you like?" or "What do I like?" I think they go with, "Well, when I was with this person, this what they like, so I'm gonna just keep doing that." And they don't get to take the time to say, "No, what do you really like?" And then goes back to your point about, if you don't know what you like, you can't teach them what you like.
Absolutely. And then somebody was like, the women start faking orgasms with men. That is a fact. You really need to stop, because when you do that, if you faking orgasms, like, he really feels that that's, man, you killing it. So, you know, he's going to carry that on in life. Like, everybody likes that. Like, and a lot of y'all it'll just keep going. It'll be fake, 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 fake. In his mind, like, that's it. So if like somebody's like, oh, well, you need to do this. It's like, no, you don't. I'm good. You know, but y'all perpetuate this misconception of just doing it this particular way. And you are making the problem worse. So talk.
So I feel like you say it from your perspective, but I'm sure you have a lot of colleagues that are female gynecologists. Do you feel like the female gynecologists say, well, because I'm a gynecologist, guys think I'm too aggressive or I'm trying to tell them what to do? Like, do you think it would interfere with a female being a gynecologist because they know about, you know, so they can really teach? Like, sometimes a guy could take a teach as training, or, you know, like they may take it as too aggressive.
No, I don't think so.
And I'm just asking because I'm sure you got friends that are female gynecologists, so they may tell you like it's just sucks.
Yeah, like, yeah, I don't think so. And maybe maybe I'm a little bit biased because like any female gynecologist that I've ever been with, like they kind of know I know, so it's not like that whole thing. So I really don't know how they are with a man I don't
Non-gynecology.
know. Right. So I personally haven't experienced it like that, but uh but I do also have, you know, I know, you know, women that have like men that are not in medicine at all or whatever. And they never say anything that it's a problem. It doesn't appear to be a problem. It really comes down with like personalities and people, you know, because if you communicate, it shouldn't be a problem. And like, even though I know a ton of anatomy, every woman is not the same. Every woman doesn't like the same thing, and it takes conversation to find out really what floats each other boats. And that has absolutely, it has more minimal to do with how much you know about just general, but how much you know about that person specifically and what they like, and that comes with communication.
All right. Well, I think that was a good one. I don't know
That
if we
was an
could
excellent one.
right.
That was dope.
I don't know if we could top that one tonight, unless we want to go back down to you giving us a school lesson. But so look, I got my own question. This is not even related to health or anything. You mentioned at the top of the hour your birthday is July 1st.
Yes.
So dispel the rumor for me, because I have a July 3rd baby, and then my husband is July 4th. So we always argue about all mothers tell the first week of July babies that the fireworks was for them. Did your mother do that with you?
She did not.
Oh, she didn't
No,
do that with
she
you?
did not.
Okay. We
She did not.
argue about that in this household a lot.
She did not. I haven't heard that one. I took it that way though,
Okay.
because since I didn't have like it, you know, I would say July kids have like a little complex because like your birthday is always outside of school. Like you spend the whole 9 months of school watching people get gifts and having these little school parties and everybody, you know, just all happy about their birthdays. And then when the summertime comes, nobody give a shit. You know what I mean? It's like, yo, I ain't had no little school party. I ain't had none of that. You know, so I think we have a conflicts. But no, I didn't. Fireworks, I always have. I enjoy my birthday and I enjoy fireworks after. So yeah, I think it's special.
Or maybe you was too late then, because I told my son that the fireworks was the day after, because they had to wait for me to bring him home from the hospital. And then my husband is adopted, so he said that when he found that out, he was like, "You lied to me about the fireworks. You lied to me about you being my real mama." Like, it was a big. It's like, you just lied to me my whole life. So
brainwashing the kids. I see what
yeah,
you mean.
we always talk about that. All right. Well, one last health question, which I think is a really good one, and then I'm gonna save the rest for next time. That's in the chat box for tonight, and it says, "Does weight gain continue if the fibroid is not removed?"
So weight gain, again, has more to do with your diet and how you live your life as opposed to the fibroid, right? Even huge fibroids, right? It's not so much removing that fibroid is going to change everything and make you small and skinny. It is more so how you live your life and how you eat, right? So even you, Carla, you had all of this weight loss, but I don't think it wasn't really from the fibroid. The fibroid in of itself was like 6 pounds something, right?
Yeah.
But it was more so the motivation after to now eat and work out and do all of these things because you felt better and you just had that removed, and just changing your lifestyle and just, you know, your mentality of how you felt after made everything different. So the fibroid helps. Like, don't get me wrong, like you are going to have some reduction of weight with the fibroid, but it's more so you living your life and eating properly that's going to make an impact.
Yeah, and I can. So for the person who asked the question, I actually lost weight before my surgery, over 65 pounds, because I thought by losing weight, I would fix the problem, because you see all this stuff on social media, like, don't eat this, don't do that, don't. And so I was like, okay, I'm gonna just try to lose weight myself. But the fibroids kept growing. When Dr. P looked at my ultrasound that I had before him to the one that I had during being his patient, they grew. So I was losing weight and my body the scale was moving and all that, but the fibroids weren't going down. So
Right.
even if your fibroid is getting bigger, it doesn't mean that your weight will go up. My weight was definitely going down. And like you said, it went down after, even though I just came back from vacation, so I'm up 5 pounds. But anyway, we ain't gonna talk about that. but my weight was going down. The fibroid was still growing. And I think I watched one of your videos where you said people are letting them get the size of a studio apartment. I felt so attacked. So I was like, oh, he's talking to me. So yeah, it was growing. It was growing.
It was a small studio though, just a small.
Yeah, I felt so attacked. So yeah, you can lose weight and the fibroid will still grow. So it doesn't necessarily relate to the weight, at least in my personal experience.
Yeah, agree.
All right. Well, I don't want Instagram to cut us off or not let you upload the video, because I see people in the comments saying, save this, I joined late. Save this, I joined late.
All right. Yeah, so I'll save it. Cool. We'll end it here. We'll do it. I mean,
yeah,
we could do it in like 2 weeks if you do. We don't have to wait a month. We
right.
can do it
and everybody, I keep the list. So please, if I did not get to your question, and if your question was reworded, it's because people ask some of the same things. So I kind of combine it and just write it one way, so it kind of covers yours and theirs, and it's all one question. So I keep your questions. I don't lose them. I'm pretty good with everything that's not a cell phone. Okay? Cell phones is not my strong point, but I'm an IT, believe it or not, for a full-time career. So
don't even tell nobody.
Okay. But not cell phones.
All right.
Not cell phones.
So y'all send her your questions. Follow her page, because she posts this to YouTube and everything else. I just posted to my page, but everything else is like posted on YouTube. So we can do it again in 2 weeks.
Okay.
So we got more stuff. So thanks everybody. Everybody is saying thank you. Thanks for tuning in. And like always, like when you got questions, just send them. If you need consults, hit me with the consult. Like, again, like don't. I want to help everybody, but like if you send me a whole book about what's going on, I'm gonna tell you, just consult and ask me, right? Because I got to take time to talk to you, figure out all type of stuff. Like, it's there for you. Just use it. But cool.
And then since you mentioned the YouTube, I want to end on this note. As they always say, give people their flowers. So I want to read you a comment that somebody posted on my YouTube that I know normally I send you stuff, but I've been busy, so I didn't get to share this one. So I'm going to read this one to you, and then we're going to end on that note, because you need to know this. Mm-hmm. All right. It says, thank you both once again for a very informative section. I am so amazed with how Dr. P's knowledge and answers straight from the top of his head. And of course, Dee, she knows me personally. You are the perfect one for this role. You all work so well together. All of these years, you really know how to say curse words. Thank you again for the excellent information. So yes, Dr. P answers this off the dome. I can't even send him the questions. The list is so long. So yes, he is giving us straight knowledge. That brother went to school. So I wanted you to know that, because people really are amazed at how helpful you are.
Appreciate it. I don't know everything. I know that. I know women's health. I got that down pat. So
yeah. Well, we're not saying you know everything.
Yeah, I'll take that. When I don't know something, I say I don't know it. But yeah, these questions I know.
All right. Well, thanks again, Doc. I definitely appreciate you. And yeah, maybe 2 weeks out, we good.
Sounds good.
All right then.
All right, Mom.
Thank you.
All right.
All right. Bye-bye.
Bye-bye.